All right, so now we're moving on to our next topic of coronary artery disease. Now, coronary artery disease and the whole group of like angina pectoris, stable versus unstable angina, all of this is one topic, and the other topic is going to be the STEMIs and how that leads to different issues. So it's all a progressive issue, just like in our last topic. We had heart failure that was compensated, then decompensated, then became congestive. Here we're going to see a continuation of things. So coronary artery disease, is it angina pectoris, which is basically stable angina due to cholesterol in the coronary vessel, like this. So you can see that there is a thinning of the lumen over here, and lesser blood is going to be able to pass through the coronary arteries. Principal angina, whole different thing. It's variable angina due to spasms. So we're going to see different triggers there. And then it could also be carotid artery stenosis, which basically you'll identify from brutes in carotids and is due to cholesterol being deposited in the carotids. It is not due to a plaque rupture. Okay, plaque rupture, as you can see in the further three images of numbers 2, 3, and 4, plaque rupture would be something that would lead to an STEMI, an unstable angina, and that is an acute coronary syndrome. Okay, right now we're looking at coronary artery disease, not an acute coronary syndrome. So we're going to see how that progression is going to be noted in patients and how you're supposed to imagine what phase the patient may be in right now. So angina pectoris, this is stable angina that lasts 2 to 10 minutes. It's caused by exertion and is relieved with rest. Now, if they tell you that in the question, that makes things a lot easier, right? They'll tell you every time they try doing something like lifting boxes at work, or of course the usual going upstairs, taking their dog for a walk, then they start feeling chest pain and they have to sit down, upon which the chest pain goes away within a few minutes. It really shouldn't last any more than 10 minutes. So if you're seeing something that's lasting 15 minutes or more, it probably is not stable angina. And that's the timing of how many minutes is after they sit down to rest. Okay, if they're still doing things that are causing them to exert energy and stuff, then of course it's not going to go away. The root cause is an atheroma causing myocardial ischemia. Ischemic pain is dull, squeezing, pressure-like, so it will not be tender, positional, or pleuritic. The type of pain can help depict if it's just GERD, costochondritis, or pleuritis. Now, these differentials are going to be a big thing you're going to have to watch out for. So basically, when you see a patient going through angina pectoris, they literally squeeze their chest like this. They often think that if they squeeze right here, that they'll feel better. Okay, it doesn't really help them much, but they can't do anything. That's the best they can do at that time, right? If it's tender, so like if you press around here for them during a physical exam and they feel pain, that's usually costochondritis. Costochondritis is actually an inflammation of the muscles and the bones in this chest area. If it's positional, that's also another thing you want to watch out for. So like if they sit in a certain way and it causes pain, that's also most likely costochondritis or some other thing like that. And then pleuritic pain is also usually due to inflammation of the pleura, not angina pectoris. Okay, so a lot of things in the real world, a lot of things common folk will describe as pain in the chest. Okay, most notably GERD. GERD is a huge issue both on the test and in America with obesity and all the different eating habits in America. That burning sensation that GERD causes, that is often also something that patients may mistaken for chest pain, even though it's not chest pain. So obviously you need to make sure you identify the GERD and differentiate that from chest pain, and then immediately put the patient on omeprazole or whatever else will help them before that GERD, of course, becomes Barrett's esophagus and then leads to other esophageal cancer-related issues, right? One of the key things you can do in these is an ECG, which may show completely normal, or it can show some level of ST depression. What you should not see is ST elevation. Okay, you don't want to see any ST elevation here, because as soon as you see ST elevation, then it's an elevated issue. Okay, that's one way I like to talk about it. So you shouldn't see any ST elevation in a patient with stable angina. Exercise stress test is key with echo to see wall motion changes, right? So you put the person on the treadmill, and then you try to see how far they can go while they're on the treadmill. And of course, as soon as they start feeling pain, you have to stop it. So that's something. You want to make sure that when you're ordering a stress test of this type for a patient, that you tell them to hold beta blockers, calcium channel blockers, and nitrates for at least 48 hours before the test. So If you're going to schedule them to come back for their stress test, they have to stop taking any of these if they are already taking it. Because remember, those medications would already cause dilation and stuff, and now your stress test is going to be kind of hindered by the medications that they're taking. Coronary angiography is the last resort if necessary. Nitroglycerin usually relieves the pain by reducing the left ventricular endostaltic pressure. Aspirin and beta blockers are very useful here. And of course, most importantly, you want to tell the patient to stop doing things that will worsen this condition and, of course, cause more chest pain in the future. Now these, coronary angiography, invasive diagnostic tests, not really something you want to use as your answer choice for diagnosing the patient, but if you have to, then that's what you'll have to do. Not always are patients able to do the treadmill stress test. Sometimes they're just too obese, or they have some kind of knee injury. Maybe they have really bad arthritis and they can't really walk long distances. Something that might be hindering their ability to actually walk on the treadmill, that's a problem. So you then have to look for a different stress test, like doing a medicinal stress test. Now, how does a stress test really work? So we have this concept of the coronary steal syndrome, right? So what you're seeing here is you're seeing the left LAD over here, and then you're seeing the left circumflex. You could also have LAD and RCA, LCA, RCA, stuff like that. Basically, what you're seeing is there's occlusion, right? So here in this image, there's occlusion in the LAD. Let me make it bigger. So you have occlusion in the LAD, which means that not much blood can actually go in that direction at all. Now, if you give them a medicine, right, if you give them a vasodilator, the vasodilator wouldn't do anything here because naturally in this patient, since this lumen is closed off, their vessel has already dilated as much as it could to try to allow blood to go through. So now if you give them a vasodilator, the other blood vessel, the others that have some blood going through it, is the one that would dilate more, taking away even more blood from that side. Okay, and that often ends up being a really big issue because now this side, which already wasn't receiving any blood, will receive even lower, whatever, if any, was making it into this vessel here and coming to this area will not make it there, and they'll immediately start feeling chest pain on the treadmill. You usually have them on a very slow speed to begin with, so as soon as you start feeling chest pain, you have to stop it, and then you make note of that. So this is a medicinal thing you do for the stress test during the treadmill. Other ways are right here, right? So you can do the EKG and exercise. You can do echo, EKG, and exercise. But if none of the exercise things are plausible at the moment, for whatever reason, the patient can't handle it, won't be able to take care of themselves as they're walking on the treadmill or whatever workout you're trying to get them to do, you're gonna have to figure out another alternative. So the exercise ECG stress test doesn't work out, then you try pure pharmacological. So pure pharmacological, you can do a stress test with just adenosine agonists like regadenoson, right at the bottom right there. So you have regadenoson, which is an adenosine receptor agonist that causes coronary vasodilation. As soon as you give them that medication, this medication is a very short-lived medication, so its effect comes and goes very quickly. When you give it to them, it's going to cause dilation of the coronary artery, and of course, one is already maximally dilated. The one that has a big plaque in it is maximally dilated. So I'm not really a huge fan of the image I found here. It was hard to find any good images, but let's say that just for simplicity purposes, I'm going to go ahead and draw my own picture. So you can see this is much thicker, right? This is really thick compared to here, right? This is not so thick. So you can see now that I've drawn the lines here, this is a little smaller. Now imagine here there's a big fat plaque, right? That means that in reality, the only amount of space that is actually here for blood to pass through is here. This is it. That's the amount of space they have, right? So this, let's say this is the left coronary artery, and this here is the right coronary artery, right? So the left coronary artery is already maximally dilated. Now when I give this person any medicine that would cause dilation of the coronary vessels, like regadenoson or even dobutamine, then or dipyridamole as well, all three of them. I've listed out all three of the most commonly used stress test medicine. When I give it to them, all it'll do is actually cause the right coronary artery to dilate more, right? But the left won't be able to dilate anymore because it's already fully dilated. So that's the coronary steal syndrome, because right now in this direction, only maybe 2 arrows of blood were actually flowing in this direction. And here maybe 3 arrows, okay? 3 arrows of blood were flowing in this direction. After giving the vasodilator, when this one dilates more, it'll take this and move it here. Okay, so now you're gonna have one arrow go from the left side onto here, and half of the blood that was going into the left coronary artery will now also be going in the right coronary. More blood will go into the right coronary artery, and that's going to be very difficult for that patient, right? That's going to lead to chest pain in that area where the left coronary artery or whatever other artery was supposed to be supplying blood, and they're not going to feel so good. Okay, and that's a sign that the patient has obstruction that needs to be managed. If you can't give them those medications, maybe because dipyridamol, it's a phosphodiesterase 3 inhibitor that can also cause decreasing of platelet aggregation, and maybe they need their platelets to aggregate, so you can't give it to them. You also can't give it to patients who are on other meds like theophylline and stuff like that. Adenosine agonists don't work very well because adenosine agonists are actually going to be fighting against things like caffeine and theophylline, both of which are very similar. And this is actually taught in the step 1 pharmacology of cardiovascular section. So if you can't give them these things, then the only other thing left to give is possibly dobutamine. Okay, dobutamine is a beta 1 agonist. So if the patient has reactive airway disease, the patient has a need for their platelet aggregation, any of these things, dobutamine is one of the safest things you can give. It's best for patients with reactive airway disease because it's not really going to cause any issues there. And it's also supposed to increase heart rate. By increasing heart rate, this one doesn't actually cause much vasodilation. It causes a little bit of vasodilation, but not so much. Once given at higher doses, it can cause some vasodilation, but initially you just want to give them the dobutamine. It'll increase their heart rate, and they'll immediately start feeling chest pain. Okay, because the increased heart rate is also going to cause more blood to go in the correct direction that is open, and lesser blood to go in the direction that is not so open, and then they start feeling weak and have a little bit of chest pain. So multiple different ways to do it, right? Multiple different ways, but there's 3 breakdowns mainly. Just an exercise ECG stress test with no medication, where you put them on the stress test, put them on the treadmill, they're walking, and then they start feeling pain, okay? Or you could put them on the medication like adenosine or dipyridamol, and if they can't take the adenosine agonist or dipyridamol, then you can give them dobutamine, right? 3 different ways to go with it. And in all 3 case scenarios, you can also add the echo and EKG to visualize things, but in reality, we're mainly doing stress tests just to see if they feel chest pain, and then you move on to other things to try to help them. So that's your stable angina, right? Angina pectoris, 2 to 10 minutes of pain that goes away with rest. There's no infarct, no ischemia. Well, a little bit of ischemia, but not really enough to cause ST elevation, right? Now, this can then progress to other worsening things. We're going to come back to that. Before that, let's wrap up the remaining topics of coronary artery disease. So you have prinzmetal angina and you have carotid artery stenosis. Now, prinzmetal angina is a variant, unpredictable, kind of a variable angina that occurs at any time. It can occur on rest, it can occur because you were doing something, it can occur because you were just sitting there, or even right from waking up, right, different times. It's due to coronary vasospasm, and it's usually seen in young women. Most notably, it'll be young women that have migraines, okay, which again is a very common statistic, right? A lot of women get migraines, more women than men get chronic migraine issues. So that's usually going to be something that's given to you in the question. It can also be due to cocaine use, which in our last video we discussed that it's usually going to be a younger person that uses cocaine, and it's going to be someone who maybe has a very demanding career where they need this energy and drive to get through their day. Okay, in America, usually the financial district. ECG may now show, in this case scenario, some ST elevation, but again, all you need to do is just give them either calcium channel blockers, plus or minus nitrates. Aspirin is actually avoided here because that can cause ischemic attacks, so do not pick aspirin. And beta blockers are also avoided here because beta blockers can cause more vasospasm. Right? One of the things that can actually trigger a patient to have vasospasm, other than cocaine, is another medication that is very commonly used to manage chronic migraines, which is triptans. Okay, so the patient may be taking something like sumatriptan, which is a medication that helps with chronic migraines. So at that point, you would have to tell them to stop taking it and maybe prescribe them something else for their chronic migraines. All right. And the last topic here, carotid artery stenosis. This is atherosclerosis in one or both carotids. Now, atherosclerosis, if you go back to step 1, if you've forgotten any of it, you want to make sure you go back to your first day, step 1, and sort of revise the topic. But atherosclerosis occurs in multiple areas, right? And there was nice mnemonic to kind of figure out, the percentage of, or the chances of having atherosclerosis in certain areas. The mnemonic was something like, after I work out my abs, I grab a Corona and pop my collar to my carotid, right? So that was abs for abdominal aorta, the most common area to get a atherosclerotic atheroma. The coronary arteries, which is the grab a corona. Pop my collar, pop being popliteal in the leg, so that would be someone who would maybe get intermittent claudication because of atherosclerosis in their leg arteries. And then pop my collar up to my carotid being carotid artery, where it's of the four, it's the least common one to get atherosclerosis, but it's not that uncommon. Of the four, it's the least common, but it's still pretty common overall. So carotid artery stenosis is something you can even feel. Okay, if it's a lot and it's very stenosed, you'll actually feel it. And when you check, you'll feel carotid brutes. You might even feel some stiffening of the carotid arteries. And those little atherosclerotic plaques can actually break off and then go into the brain, causing transient ischemic attacks or embolic strokes, something that may actually be in the patient's history. Duplex ultrasonography is really critical to determine the percent occlusion, and this gets a little technical. Men with more than 60% occlusion and women with more than 70% occlusion are the only case scenarios where you actually do a carotid endarterectomy and you actually have to take the stenosed part out. All right. Smaller lesions may simply be monitored with uh, future visits through ultrasound, so ultrasonography. You have to make the patient come back on a regular basis to make sure that the occlusion isn't getting any worse. And of course, put them on medications like statins and stuff, and give them advice on things they can do to better manage their atherosclerosis. For all three of these case scenarios, stable angina, principal angina, carotid artery stenosis, the main coronary artery diseases that are due to atherosclerosis, you probably and most definitely will see in the patient a history of diabetes, hypertension. They're probably smokers, and they often also just don't really have a very athletic life. So that's something you want to watch out for. Now, this angina pectoris that we talked about, this is the thing that can now progress. You see the plaque here is closed, right? And remember, from atherosclerosis, this is all like endothelial dysfunction. Then there's LDL accumulating within the vessel. There's a bunch of monocytes that are adhering here, and you start seeing foam cells, the development of an atheroma. Growth factors and platelets and whatnot start attaching here. And then activated macrophages start coming in, right? The activated macrophages are the problem here because they're going to start kind of trying to break this down. But one more thing that happens in the development of atheroma is also smooth muscle proliferation, right? Smooth muscle cell proliferation on top, and you get a little cap on it, and then it's kind of stable until something ruptures it, right? Now, the fibrous cap and the fatty streaks, those are other things that you're going to see if if the patient's dead and you're now looking at their coronary arteries. But eventually, the macrophages can break out, okay, and now you have rupture. When it ruptures, that's when you are now in acute coronary syndrome. So it's acute, it's easy to understand it's acute because it ruptured, it just happened. As soon as it ruptures, now big issues start happening. Now you have the case scenario of unstable angina and non-ST elevation MI. So at this point, at this precise point, you usually get ST depression, all right? So you're seeing here unstable angina, the plaque ruptures and the thrombus forms around the ruptured plaque, causing partial occlusion of the vessel. Angina pain occurs now at rest, right? So unstable angina is chest pain at rest due to plaque instability. It just now ruptured. Stable and unstable angina do not have elevated cardiac biomarkers, so you're not going to see any major troponins or stuff like that. You can see here troponins are normal. Thrombolysis and MI risk score. This is called the TIMI score, TIMI. Thrombolysis and MI risk score of 3 or more requires you to give enoxaprins. Now, how do you calculate this TMI score, right? The thrombolysis and MI risk score. So the TIMI score is a table among some of the other scores we've looked at that is in the book, First Aid, but mainly it's a pretty straightforward thing. Is the patient older than 65? Has the patient got other risk factors like family history of it, diabetes, smoking, hypertension, high cholesterol levels, a history of abdominal aortic aneurysm, those two? Any of those things, so that's 2 points so far. Does the patient have known carotid artery stenosis or coronary artery disease? Right? Does the patient have a known coronary artery disease? If they're known for having something like stable angina due to coronary atherosclerosis, then that counts. That's already 3 points. And then the fourth is if they've used aspirin. If they're already taking daily aspirin, then those things get them 4 points right there. If the next few points you can get are based off of their presentation. If they're presenting with severe angina, so maybe they get chest pain 2 to 3 times a day, that gets them a point. If you're seeing any ST deviation, whether it's ST depression or elevation, that gets them a point. And then if you're finally actually seeing cardiac markers like troponins, that also gets them a point. So the TIMI risk score for unstable angina and STEMI can actually go up to 7 points. All right. And these are all things that are pretty straightforward because when you get a patient with chest pain, these are the things you're looking for, right? Are they really old? Do they have any of these other comorbidities that are bad and pretty common in America? Do they have known coronary artery disease? Do they take daily aspirin? Do they get a lot of angina, more than 2 episodes a day? Do they have any ST changes on ECG? And do they have any biomarkers? Okay, 7 different things, each of them getting them a point. But as soon as they have 3 points, which is really easy to accumulate, as soon as they have 3 points, you now need to give them enoxaparin, a GP2B3A inhibitor, and you need to do early angiography to really find it and diagnose it correctly. Analgesia with IV morphine and IV metoclopramide will actually be really helpful as well. The IV metoclopramide is also going to help them not vomit. Keep in mind that vomiting and nausea, these are some common symptoms that are less common than all the other symptoms, but it's still a very common symptom in patients who have MI or have angina. So don't get confused if the patient vomited. Don't start looking at other answer choices that might be better fitting for vomit related things. You want to look at the whole picture. If they have chest pain and they're vomiting, then it's most likely an MI. And in women, it's even more common for them to vomit. Aspirin is used to reduce mortality in acute coronary syndrome, and clopidogrel is also given unless it's contraindicated. LNWH is like enoxaparin are going to help prevent clots in the coronary arteries. Heparin is recommended for STEMI, and thrombolytics are only recommended in STEMI if PCI is not available within 2 hours, right? So when the patient presents with unstable angina and they have STEMI, and it's still been within 2 hours, then you can do PCI, right? Percutaneous coronary intervention. But if it's been more than 2 hours, then you can't do it anymore. So then you have to go ahead and give them thrombolytics. And then, of course, DAPT should be considered for up to 12 months after angioplasty or stenting. So what's happening here, right? This patient that just came in, what are we trying to work on for them? And this whole score thing and the medications, et cetera, how are you supposed to remember all this? So what is DAPT? DAPT is a very important thing. That's dual antiplatelet therapy with like aspirin and prasugrel or aspirin and ticagrelor, right? These are the P2Y12 inhibitors that are even better than clopidogrel. These medications are going to be very important because remember, when the patient comes in with any of these issues, managing them in the hospital is the easier part. It's after they're released and that they go home, the other modifiable risk factors that they don't modify, those are the things that cause the bigger issues for the patient, like smoking, eating lesser salty foods, lesser fatty foods, not eating too many sweets, managing sugar, taking meds correctly. All of these things that are outside of your control as a hospital in the inpatient, as a doctor in the hospital inpatient setting, those are the things that are going to be a big problem, right? So you want to put them on DAPT and then just kind of send them home with the correct education and hope that things get better, okay? Abciximab, tirfibant, eptifibatide, these are your GP2B3A inhibitors that you're going to be giving during the angiography. But when you're trying to revascularize them within the 72-hour period. But when you're releasing them, you want to put them on dual antiplatelet therapy with aspirin. So they're going to be taking a couple things once they get home. Now, this unstable angina, right, this is the part we were at. If they didn't come in for help in time, maybe the plaque rupture wasn't really causing symptoms so bad that they come in, so they're doing all right. If this doesn't happen, then it can get worse. Now, it can rupture even more. Right, so during an STEMI, the plaque rupture and thrombus formation cause partial occlusion to the vessel that results in injury and infarct to the subendocardial myocardium. Okay, so the inner part of the heart, as you can see over here, you have a subendocardial infarction. That part of the heart is not getting enough blood, and it's kind of just starting to die. All right, and it's also not going to function that well, which means that their ejection fraction is going to start falling, and they're not going to get enough blood out of their heart into the rest of their body and brain. Now you start seeing ST elevation. Okay, so sorry, ST depression. Excuse me. It's still an STEMI. So at these two places, unstable angina and STEMI, unstable angina and STEMI still have ST depression. And the way I like to memorize this when I first came into this topic was that it's depressing to be heard from the inside, right? So that's what you're seeing here. This is all inside, and the damage is subendocardial. So depressing. This is a very depressing injury. It's hurt on the inside. So you see ST depression as you're seeing over here on most of the QRS complexes on their ECG. And at this point, what I meant to say earlier is now you're going to start finding cardiac biomarkers like troponins. Okay, so the patient may start showing you a lot of elevated troponins, a lot more chest pain that isn't going away, and they may be sweating. Maybe they have some weird feeling on the left shoulder and in their face, and a bunch of other symptoms that are going to be popping up. The whole case scenario is going to look a lot worse. And if you look at the whole picture, now you know they have NSTEMI, and you again same management, same stuff. It just depends when they came in. Did they come in before they have elevated troponins or after they have elevated troponins? All right, and if you still couldn't do anything about it, and maybe they came really late and the disease has progressed really, really bad, then this can fully mess things up. And now they get ST elevation MI, okay, a full-blown MI. A STEMI is characterized by complete occlusion of the blood vessel lumen, resulting in transmural injury, right? So the whole wall is broken. The entire scenario is elevated. This is a big problem. It's an elevated problem, ST elevated MI, right? So now you're going to see ST elevation as opposed to ST depression on the ECG, right? So this image here does a good job showing you the progression, and this whole progression is not like it takes months for it to occur, okay? The stable angina part, this part, development of the atheroma takes a long time. That happens over a long period of time where the patient didn't really take care of themselves in their diet and their exercise. This portion here of unstable angina may not exactly bring the patient into the clinic if they're trying to manage it and they're doing all right. Okay, they're just going to be doing their best to kind of just get through it, all right? And then maybe they're too busy to come in, or they're too lazy, or in America, other issues are like maybe they're an illegal immigrant and they're afraid to come in, or maybe they're just too poor and they don't have any health insurance, so they don't come in. So from here to here, it doesn't take too long. Maybe a day, maybe two, depends on how the patient lives and what are the comorbidities they have. This rupture can worsen and then quickly lead to complete occlusion. So progression from 2 to 4 doesn't take too long. And it's very critical that the patient come in as soon as possible for help. Right? Now, if it gets to an ST elevation MI, now you're talking about chest pain that lasts 10 to 30 minutes as opposed to the stable angina, which lasted 2 to 10 minutes. It could present without chest pain, which is a silent MI, but patients usually have tightness radiating to the left arm and shoulder with possible vomiting or epigastric pain, as we discussed earlier. ST elevation and elevated cardiac biomarkers, inverted T waves, pathologic Q waves, ECG will be evolving as the patient goes through phases of MI and recovery. Troponin peaks at 36 hours, and CKMB, the other cardiac biomarker, peaks at 24 hours. So if you see a second peak of CKMB, that is usually a second MI. This is another question you can actually get. So what you're basically seeing is something like this. So imagine like you have a graph and they tell you that troponin I was, super high, and then over some time it decreased. That's what that's going to look like. CKMB will also similarly rise at the same time, but then that comes back down quicker. Okay, so since troponin I takes a long time to come back down, if you're going to be thinking, oh, this patient may get a second MI, you can't be watching troponin I anymore because it's going to be high for a very long time. So you watch to see if CKMB went up again. So you see how CKMB can go up and come back down and then go up again while the troponin I is still elevated. Okay, so you have to watch CKMB just to keep an eye on the patient to see if they're getting a second MI while you're trying to treat them. Depending on where the MI occurred, depending on which artery is blocked, you're going to see different elevations in different parts of the ECG, which we discussed earlier in our ECG video. And we looked at this diagram. Let's see. In one of our earlier videos where we talked about the ECG, we saw this, right? So here you can see like which leads are going to show ST elevation, which leads are going to show the actual person having symptoms, right? So for example, anterior MI, you're going to see ST elevations in V1 through V4, most notably in V3 and V4, right? There's going to be ST elevation. Lateral MI, posterior MI, and the most common inferior MI, which is related to right coronary artery, 2-3 AVF. Right? So that's what they're talking about when they say, what part of the ECG you need to look at to kind of identify where the occlusion is, where the real problem is in that patient. Aspirin decreases mortality in acute coronary syndrome, and a dual antiplatelet therapy with prasugrel or ticagrelor is really, really critical, as we discussed earlier, right? IV morphine, nitrates, oxygen, just like the element OP mnemonic earlier for when we looked at myocardial infarctions, is all going to be very critical. But again, you really, it all depends on the timing of their presentation, the severity of their presentation, and what you can do for them based off of their various problems. Okay. Something you want to make sure you spend some time on is the progression of an MI. So how badly it's progressing, what stage the patient is at when they're having their MI, and often again that leads to other questions that we looked at earlier when we talked about the topic of myocardial infarction in our previous videos, is questions regarding things that happen after an MI, right? So like pericarditis that can occur because of early inflammation, the wall breaking that can occur, whether it's a pseudo breakage or an actual full rupture of the myocardial wall, Dressler syndrome, time period, right? How long it takes, and we had a very logical discussion about all of that in one of our earlier videos. So make sure you go ahead and check that out and understand the progression of an MI. Make sure you go revise the progression of an atheroma and how it develops, and really understand the difference between stable angina, right? Because these are different chapters in first aid, right? Stable angina, which goes under angina pectoris of coronary artery disease due to atheroma, versus unstable angina, which is an acute coronary syndrome. Right now, there's rupture and there's actual bigger occlusion, which then quickly evolves to NSTEMI and then STEMI. Right, so what's elevated in terms of cardiac markers and what's happening on the ECG, ST depression, ST elevation, these are all going to be very critical to figure out exactly what's wrong with the patient. And generally speaking, treatment-wise, not much of a difference for these case scenarios, 2 to 4. But you want to make sure that you understand the way to diagnose them, because that's going to be the majority of your questions. Now, on our next topic, we're going to move on into dyslipidemia, and I'll probably do some practice questions with you guys before we move on into that topic. So I'll see you guys then.